Hello, this is Mark Jolly. We're going to talk a little bit about edentulism and how to think like a prosthodontist. First of all, the mouth is an extremely difficult environment to place any sort of object and expect it to have success in recreating teeth or helping with chewing function. It has a wide range of pHs. It has a wide range of temperatures it's exposed to. It's constantly under mechanical pressure, and basically it's continually wet, which makes it very difficult to have anything succeed in this environment. So it takes a little bit of creativity to think of materials that can really work in this sort of environment. So, thinking about the difficulties of building a denture and having it succeed, we were given the challenge to build a denture out of anything we'd like. I chose to make mine out of dirt. So why dirt? Of all the materials I could have picked, it doesn't seem very hygienic. Well, I largely picked it because it's very common, can be found about anywhere in the world, and if you could find a sanitary way to use dirt, it would be a lot cheaper than our alternatives. Here's a look at the finished product. Now don't worry, this was never placed in a patient's mouth. It was just a hands-on experience to understand how to build a denture. So if it's hard to make dentures, and it costs lots of money, why don't people just go edentulous? Why don't they just grind up their food by hand? Let's talk a little bit about that. Some patients decide to go without dentures. These patients are faced with many consequences, including dietary, they can't eat many foods, and also social. It's difficult to be able to smile, feel comfortable talking with people if you're missing your teeth. However, with that being said, wearing dentures is not easy either. Let's take a look at my experience wearing a self-made denture for a day.
There were three things that I hated about my selfie denture. First of all, due to the model, it had some occlusion on my mandibular left side, and it just was gritty and drove me crazy all day. Second thing was, I'd cut it very sharply on the back, and it started to rub against my tongue, and it hurt. Third thing I didn't like about it was the taste. Every time I'd put it in, or take it out, or swallow, it made me gag. Overall, this has been a very good experience in helping me empathize with people with dentures.
So if it was so uncomfortable, why not make some better options? Well, we do actually have some pretty decent options in prosthodontics. And let's take a look at some of the various appliances that a edentulous patient could pick from. Let's start with the most obvious option, the denture. The denture is not a bad way to go. It's the cheapest appliance that you could get. It costs roughly between $1,000 and $2,000 per arch in a regular dentist office, and there are cheaper options out there as well. The downside is that you only get about 10% of the strength chewing, and you will have resorption continually throughout your life and have to be refitted and retried for the dentures on a regular appointment. Alternatively, you could go with a fixed removable denture. This employs the use of implants to give you a little more strength, better mechanics, and makes it so that the denture doesn't slip and slide as much as it would. The downside is this costs, about $7,000, and it doesn't actually give you full chewing capacity. You're still about 50% of the strength that you'd have of a real set of teeth. If you have a great deal of money, you could go with the best and get a hybrid. This system is literally screwed into the jaw. It's there, it's always there, but it functions pretty well as teeth. It gives you 100% strength, and it's not something that requires as much maintenance as the other options. The downsides besides cost is that it actually requires quite a bit of space in the mouth, which could require removing some bone potentially in some patients in order to install it. However, it's by far the most comfortable for the patient and the longest lasting. So let's talk a little bit about what we're trying to achieve with dentures, in particular the aesthetics of dentures. So there's basically three laws of idealism that we're going to talk about and how they are reflected in a patient's mouth and how we perceive them. To illustrate the point of idealism, we're going to take a look at Heidi Klum's mouth. So macro-idealism is the first thing we're going to look at, and that's kind of your basic impression from across the room. Are there any facial deformities, any imbalances in the face? Is one side larger than the other? Does the jaw seem to be formed correctly? These are things that we'd notice, and they obviously are the largest problems. If there are problems, they are very noticeable to us. Of course, many people don't go to a dentist for a massive facial reconstruction. They would rather go for what we call meso-aesthetics or meso-idealism. And that's the idea of how the teeth and the lips interact, how they look together. That's the primary responsibility of the dentist, is to help a patient feel confident in their smile, and basically meso-aesthetics. Lastly, we'll look at micro-idealism, which is just the interaction of teeth to teeth. Basically, how they look next to each other, how well they function. This is primarily the responsibility of the lab tech in denture making. The laws of idealism are here to help us as a guide. They basically help dentists to make good decisions regarding how the teeth should look, how they should function to allow chewing, and also how they should sit in order to allow the formation of different sounds in speech. So we've talked about some options that edentulous patients have, and we've also talked about the laws that govern dentist choice in making appliances. Now let's take a look at the actual process of creating a denture. First things first, we have to know what we're working with. We need to take an impression of the mouth. Once the impression has been taken, we need to go and make a stone model of the mouth. Using this stone model, we're going to next make a custom tray for the patient. I should mention here that there are actually many different ways to make a denture, and this is just one of them. Using the custom tray, we'll place it in the patient's mouth and have them feel it for any sharp edges or bumps. We'll also note where the posterior palatal seal is, an area of the mouth that can be depressed and basically allows for better suction. With the information we acquired from our custom tray, we'll construct a triad base and we'll place on it a wax rim. Using the wax rims, we'll mark the midline just by making a small scratch about where the central incisors belong. We'll also just test the vertical dimension and make sure that they feel comfortable, removing once again any sorts of bumps or sharp edges from the denture. However, for our class, we only had one copy of the original wax rims. Therefore, each of us had to make our own copy and had to build off of that. So the first thing that we did as a class is we took the information acquired from the custom trays and made our own stone models. We then used this information and made triad bases, which we placed on both the mandibular and maxillary arches. We then heated and folded wax in order to accommodate the dimensions of the arch. Once the wax has been placed on its triad rim, we can then begin carving and placing teeth. I should also mention here that we were using an articulator in order to maintain the correct dimensions of the patient's mouth throughout this process. Here's the placement of some of the teeth. Notice that we had to find the midline first in order to start this part of the arch. With the help of an articulator, we're able to make the first arch. Here's both of our finished arches. We've aligned them on the articulator, and we've made sure that the bite works. It should be noted that you can't always make dentures idealistically. We do have some constraints that we'll talk about a little bit later on how we can make the dentures to fit the patient's mouth. At this point, although the dentures look mostly done, we still have a few steps left. We need to try them in the patient's mouth, see how they fit, and also work a little bit more with the lab to get them done. Fortunately for us, we have amazing patients to help us. Ross here is going to try in his denture, and we're going to look at him and see what his thoughts were. Here Ross is placed in the maxillary arch. His first impression is that it doesn't stick well. It obviously will need some work if it's going to stay in for him in the long term. Here Ross is placed in the mandibular arch. He notes that there are a few sharp places, which I then smooth out with a slow speed. Here we also test the occlusion and make sure that he can chew with the new dentures. Once that's been established, we have to test phonetics and make sure he can say sounds correctly. Teeth play an important role in making correct sounds as we speak. I'd like to take a moment just to say how grateful we are to patients like Ross that are willing to take time out of their day to come and help us to learn how to make dentures and how to do great dentistry. I've alluded to this before, but there is a problem that faces denture makers, and that is resorption. Basically, the bone starts to disappear once you've lost all your teeth. Now that we've established that bone does resorb, let's talk about the pattern in which it resorbs. In the maxillary, the ridge resorbs superiorly and medially. meaning that the arch gets smaller and smaller with time. The mandibular is trickier. The mandibular arch actually resorbs 4 times faster than the maxillary arch. The sides of the mandibular arch continually resorb laterally and inferiorly. The anterior portion of the mandibular arch first recedes inferiorly and posteriorly, but then switches and it goes to going inferiorly and anteriorly. So from these patterns of resorption, there's actually 3 classifications that we give to denture patients. Class 1 denture patients are the new denture patients. They haven't been edentulous long enough to have much resorption. Therefore, their maxillary and mandibular arches line up about how they would with teeth. Class 2 patients have had resorption on both of the maxillary and the mandibular arches. This has basically caused them to have a big overbite. The reason being is that the mandibular arch has receded, like we said before, posteriorly. Lastly, we have class 3 patients. And since the pattern of resorption has changed in the anterior mandible, we basically have an underbite, and we also have some problems in that the mandibular arch is much wider than the maxillary arch. Because resorption is a real challenge in denture making, we have to have a way to deal with it, and that is reliners. To do a reline, we're coating the entire surface area of the denture with an acrylic. And basically what this does is it builds it up and we fit it back to the patient's mouth. By doing this, we can account for resorption and help the denture to fit again. In order to compensate for resorption rates, patients will have to come in about every year to get relined. After years and years of having relines, this can add quite a bit of material to a denture. Sometimes we actually have to remove that material. This is called a rebase. Basically, the lab will take the denture and remove excess layers of the bottom. They'll then fit it to the patient's mouth. This allows for a less gummy appearance in the denture. Obviously, there will be times when a patient will break a denture. We can actually repair them. There are numerous kinds of flowable materials that we can place in cracks. We can also replace teeth. We can also fit the bite to patients as it changes. We can do pretty much anything they really need for repairs. Of course, everything comes at a price. I've alluded to this before, but we are grateful for our patient pool. As a class, we just really learned so much from both Ross and Hermie, and we'd like to thank them for their attendance and assistance. If there's one thing that we've learned, it's that we have to be professional with our patients. We need to absolutely be there for them. They need to be able to trust us. They need to be able to talk with us. And we're grateful that we were able to work with Ross and Hermie in this case. As far as my class, I've always been very impressed with them and their professionalism. They treat patients extremely well and give us a great standard to move forward with. So, thinking about my first experience with dentures, I had to come up with basically an idea of how I could best help patients in the future. As interesting as this might be, it's been found in studies that the most important factor in patient satisfaction regarding dentures is actually the relationship between the dentist and the patient. If the patient feels understood and they feel like they're talking with a friend, it's always going to be a better situation. Therefore, my goal is to befriend all of my patients, to make time in my schedule to have a legitimate consultation and talk about their options honestly. I think that this will make a huge difference with patients as I go forward with my dental education. I'd just like to take a moment to thank you for watching this video. This was all a project for Prosthodontics class that we have at the University of Utah Dental School. Dr. Durham has been a great professor. We're grateful for him, and we're grateful for the experience that we had working with patients. If you have interest in becoming a patient at the University of Utah's Dental School, we'd love to have you. Please look up our homepage. It's in you just look at the University of Utah's pages, and you'll find our dental page. And we'd be happy to have you for a consultation. We hope to see you there.